It's a great pleasure to me to speak here as a nuclear medicine physician to an audience of so many oncologists. But the topic the title of this topic is very interesting. As we all know, functional imaging obtained by positron emission tomography, especially performed by FDG, has been an established imaging method in oncology since the end of the 1990s. Lately, the combination of PET and CT in a single gantry system has been introduced with the advantages acquiring images in the same session, combining data of both techniques into co-registered images, and aligning, correlating the distribution of metabolic or biochemical activity in the body with anatomical imaging. So this has become a new challenge for the assessment of disease. During the last years, new cancer therapies have become more and more important, and we all know response rate must be viewed with some caution trying to predict outcome. Lack of progression may be associated with improvement in outcome, even in the absence of major tumor shrinkage. Conventional imaging techniques and research criteria are usually applied based on changes on tumor size. Not able to early identify patients with a poor progressive-free survival during targeted therapies. So new concepts are under discussion for CT, for MRI, and of course for PET. But there's relatively little systemic integration of PET into clinical trials of new cancer therapies, probably because due to variable in study performance across centers, lack of uniformity accepted and practiced treatment response metrics of PET, and also accepted and standardized PET machine calibrations and quantification concepts. Recently, qualitative FDG PET reading at the end of treatment has been integrated into cancer response assessment of lymphoma disease, head and neck, breast, lung cancer. But quantitative measurements of tracer are a discussion because we have a lot of possibilities to describe and quantify these measurements as standard optic values normalized to body mass, normalized to body weight. We can describe the maximal LVV as SUV90. But it seems to be very interesting for probably early induced therapy changes. Of course, the societies of nuclear medicine have taken some effort to define qualitative and quantitative approaches. For example, for the lymphoma disease, the UATC criteria, the PERSIS criteria, recently published in 2009, and also the standardization of PET and PET-CT protocols were established. So the assessment of response to anti-angiogenic therapy is for all imaging methods an ongoing challenge. FDG, as the most used tracer in PET tracer in oncology, has been investigated in renal cell cancer since the early 1990s with controversial data regarding staging and restaging over sensitivities of 60 up to 100%, specificities of 80 to 100%. But I have to mention that all these studies have been elevated based on a single stand PET machine and not integrated PET-CT. The first publication established by at least a software-based co-registration of standalone PET and CT did not show any significant difference to conventional imaging techniques in recurrent renal cell cancer. And FDG seems also to be useful in post-operative surveillance, giving additional information up to 20% of patients or changes in therapeutic management in up to 11%. In the past, the low detection rate of primary tumor was always explained because of the high physiological tracer uptake within the kidney. I give you now an example how probably integrated PET-CT can overwhelm this problem. You have an axial view of an FDG PET through the left kidney. You see here the high tracer uptake within the kidney. On the left side, you have the corresponding contrast enhanced CT, and on the right side, diffused images. And beside the high tracer uptake within the urine collecting system, now you can also align this slight but focal tracer uptake here around to the tumor lesion found by CT. In the 1990s, there were also discussions and controversial data regarding correlation of tumor grade and FDG uptake. But more recently, the prognostic value of FDG pattern has been described with higher 5-year survival in FDG negative renal cell cancer. And this is a phenomenon we can also observe in hepatocellular carcinoma, for example, or the neuroendocrine tumors. So is FDG a surrogate marker of response to targeted therapies? I tried to summarize here some of the most cited and most interesting papers dealing with this topic. But what you can see here is small numbers of patients, different treatment strategies, different imaging protocols, different treatment evaluation concepts. The time interval is different. So what can I tell you, what can I summarize? FDG-avid metastatic renal cell cancer patients with low uptake before treatment have a longer progression-free survival. Higher FDG uptake and increased number of lesions seems to correlate with a shorter overall survival. And a decrease of up to 75% of FDG uptake in soft and skeletal metastases were observed. What about FDG PET and conventional imaging techniques? There was a clear discrepancy of response evaluation between PET and CT after 2 cycles of therapy, decrease of FDG uptake but unchanged number of lesions after some weeks of treatment. What about FDG and prognosis? Patients with partial metabolic response or stable metabolic disease seems to have improved prognosis. And a significant decrease of FDG uptake early after start of therapy seems not to be prognostically relevant, but the PET results after 16 weeks, as you can see here, published by Kayani et al. in 2011. The scan prior to therapy, 4 weeks after the start, with a decrease of FDG within the tumor lesions, but 16 weeks later, new lesions were discovered. Besides FDG, there are also some other very interesting traces. For example, carbon-11 acetate. It's a surrogate of lipid metabolism in the cell membrane associated with tumor growth. And there are few studies in renal cell cancer with unfortunately inconsistent results regarding detection of primary tumor metastasis. But there were really strong limitations because of different study protocols: fasting time, injection dose, scanning time, and so on. So probably this seems to be an interesting tracer for further studies. And there's a very interesting case report of sunitinib response showing acetate response to this therapy by acetate in an FDG-negative renal cell cancer patient. Here an example performed at our institution in a patient with metastatic renal cell cancer. On the left side, the acetate plate, on the right side, the FDG, and you can see here pathological tracer uptake within the mediastinum, quite corresponding to the FDG result. But we can see also here focal tracer uptake in the rib, in the oosacrum, corresponding to very small osteolytic metastases shown by CT. And also here, in the region of the left kidney, 3 hot spots corresponding to the tumor lesions in the left kidney. Another very interesting tracer is FLT. It's a marker of tumor proliferation. And in 2011, there was a very interesting publication showing an increase of cellular proliferation found by FLT PET imaging during the withdrawal of sunitinib therapy. And they concluded that this is consistent with the VEGF receptor tyrosine kinase inhibitor withdrawal flare. So let me summarize and conclude. PET and CT in a single gantry system improves the anatomic location of abnormal tracer accumulation and the highest staging accuracy than PET or CT alone. Positive FDG PET is predictive for the presence of renal cell cancer and complement anatomic imaging modalities. The FDG uptake within a tumor lesion and the number of lesions seems to correlate with prognosis, and treatment-induced metabolic changes in FDG-avid metastatic renal cell cancer seems to be prognostic. There is some evidence that other traces such as acetate or FLD have an impact on restaging, staging and therapy assessment in renal cell cancer. But for further studies, we have to consider some aspects. Larger study populations accepted of standardized or PET imaging protocols and treatment evaluation concepts. The timing of imaging seems to be a very important question, and we should not forget probably combinations of different imaging modalities, but not only PET and CT or PET and MRI, probably combined with diffusion-weighted MRI, but also combining different PET traces, but also imaging modalities with laboratory tests. Thank you for your attention.